Good afternoon, everyone. Welcome and thank you for joining this afternoon's Dare to Think CPD webinar. My name is David Shukla. I'm a clinical research fellow at the University of Birmingham and a GP in the West Midlands. So with my fellow Dare to Think research team, we've been running a series of webinars over the last year or so. And in response to feedback from our GP and primary care research teams operating across hundreds of practices in England that are taking part in the Dare to Think study, we're continuing this CPD series this year and opening it up to a wider audience. And we're sticking with cardiovascular related topics that you've suggested. So please keep those suggestions coming in. Before I introduce our speaker today, I just wanted to give a background to those who are joining that haven't been part of the Dare to Think trial. So for the last couple of years, we've been running a digitally enabled, decentralized, randomized controlled trial across primary care EMIS practices, recruiting patients aged 55 to 73 with atrial fibrillation and a lower stroke risk, either to receive a DOAC or continuing without DOAC therapy in the usual care control arm. And we're investigating whether DOACs can reduce premature death, strokes, and other thromboembolic consequences of atrial fibrillation in younger patients, including the prevention of cognitive decline and vascular dementia. We recently reached a milestone of 800 recruits into the trial, and we're still welcoming new practices, PCNs, federations. So if you're not already part of the trial and you want to find out more, do get in touch. We can send over details or arrange a meeting with you. We're very proud that the trial has involved a wider workforce. We're aware of innovative schemes where GPs have a more minimal role in the trial, and the bulk of the work is carried out by nurses, paramedics, pharmacists and other team members. Alistair, our trial manager, he'll cover the trial updates at the end of this short webinar. So without further ado, I'm delighted to introduce today's guest speaker, a colleague from the University of Birmingham, Professor Clare Taylor, who's a professor of general practice and also a GP in the West Midlands. Clare's research around earlier diagnosis and improving prognosis for people with heart failure has resulted in over 100 peer-reviewed papers and informed international heart failure guidelines. Clare joins us today to update us on heart failure diagnosis in primary care. And Clare, I'll hand over to you. Thank you.
Yeah, so thanks very much to the Dare to Think team for the introduction and for the invitation to talk today. As a practicing GP, it's really great to be able to share my research with primary care colleagues. So I'd like to take you through 3 key papers that we've published as a research team recently looking at heart failure diagnosis in primary care. So as David said, I'm a practicing GP at 3 Villages in Stourbridge. I'm a researcher at the University of Birmingham, and I was also on the NICE Chronic Heart Failure Guideline Committee. So just a bit of background on heart failure. So around 1 million people are living with heart failure in the UK, and around 200,000 are newly diagnosed each year. And statistics show that up to 80% of these new diagnoses happen in hospital. But patients have been living with their symptoms for a while. And because of their multiple long-term conditions, so patients diagnosed with heart failure often have 3 or more long-term conditions, they are seeing their GP and their primary care team fairly often. And it is a treatable condition. So there's large randomized controlled trials showing that drugs such as ACE inhibitors, beta blockers, MRAs can improve prognosis, reduce hospitalizations in patients with heart failure with preserved ejection fraction. And more recently, the SGLT2 inhibitor trials have shown that we can improve outcomes for patients with heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And the primary care team really is key throughout the heart failure pathway, from diagnosis through to management and indeed end of life care, whether they are dying from their heart failure or patients are dying with heart failure but from something else. So the first slide I'd like to show you is about a qualitative study that we did with patients with a new diagnosis of heart failure. So I asked them to tell me about their diagnostic journey, tell me about their story. And this is a quote from one lady who said, "I just thought it was probably my age. I don't think I thought it was the heart to start with. No, I just thought that it was because I was walking a long distance and I needed to stop." And I think this is something that we see a lot, in that awareness of heart failure amongst the public, amongst patients, is pretty limited. And as a GP, I don't think anybody has ever come into my consulting room and said, "I think I've got heart failure." So the term itself can be very frightening, and patients can feel like it's almost an imminent demise when they're given that diagnostic label. But we wanted to look as a research team about survival rates for patients with heart failure in primary care. And so this is the first of the 3 papers I'd like to share with you. It was published in the BMJ in 2019 on Valentine's Day. And this is using large GP data sets, so CPRD, which many of your practices might contribute data to. And as researchers, we can suck out this anonymized data and see what's happening at a population level. So CPRD covers around 15% of practices in England now. And we had a large cohort of patients with a diagnostic code of heart failure. And we could link this data to hospital episode statistics, so see if they'd been in hospital or not, and also ONS death data, so to see what date they died and what they died from. And overall in the cohort, we had 56,000 patients, which is far larger than any sort of screened cohort study where you would actively recruit patients into the study. And it really reflects what's happening in general practice more generally. And this is the headline figure that we found. So overall, from the point of diagnosis, 1-year survival rates around 80%, 5-year survival rates around 50%, and then 10-year survival rates around 20 to 25%. But the thing that we were quite alarmed by is that these figures have not really changed over time. So our cohort looked at data from the year 2000 up to the end of 2017. And as you can see from the graph, the survival rates have barely changed over almost 2 decades. So there was an increase in survival of around 5 to 6% at the 1, 5 and 10-year time points. And if you looked at cancer survival rates, that would look very different. There've thankfully been huge survival gains over that same period. So there is a lot to do in terms of heart failure to improve outcome for these patients. So this is a Kaplan-Meier survival curve. So the y-axis shows survival, and then the x-axis is time. So over time, as you'd expect, patients die. The top line, the purple line, shows those age and sex matched control patients. So we matched each patient with heart failure to another patient in the same practice of the same age and the same gender, but otherwise they didn't have heart failure when the patient did. And as you can see, those without heart failure, the purple line, did much better. But the other 2 lines are also interesting. So the yellow line is those patients with heart failure who were diagnosed and managed in the community around the time of diagnosis, whereas the dotted pink line, is patients who were admitted to hospital around the diagnosis. So that shows that patients admitted to get their diagnostic label of heart failure do far worse and are more likely to die than those patients diagnosed in the community. And I think that's an important lesson for us in primary care, to try and get that diagnostic label earlier so we can initiate treatments. So what does NICE say about heart failure diagnosis? So we should, in patients who we suspect may have heart failure, so they're patients presenting with symptoms such as breathlessness, fatigue or exhaustion, ankle swelling, we should measure a natriuretic peptide test, and NICE recommend NT-proBNP, which is what's generally available locally to us. And depending on the result, depends on how fast we should be getting patients seen for a diagnosis. So if the NT-pro is above 2000, so high, we should ask for a specialist assessment and echo, which should be done within 2 weeks. If it's 400 to 2000, that assessment should be done within 6 weeks. And if the level's below 400, NICE recommend that heart failure is unlikely and so to consider other diagnoses. So we as GPs fill in the form, we put in the MP results, but certainly from my experience, these timeframes are optimistic, given the restraints in the NHS at the moment. But what do we need to think about with the natriuretic peptide test result? So as with any test, it can be influenced by several factors, and certainly when we're interpreting MP test results, we do need to bear these in mind. So lots of things can increase the MP level. So if the patient's tachycardic, hypoxic, potentially got a PE to explain their breathlessness, if their GFR is less than 60 or they're septic, then their MP level may be raised because of those factors. And certainly age, if we did an MP level on everybody over 70, there'd be an awful lot above 400. But equally, there are factors that can decrease the MP levels. So in patients with obesity, Afro-Caribbean ethnicity, or in patients that are on medications such as ACE inhibitors, diuretics, that can push down the MP levels. So if you've got a patient who is symptomatic potentially of heart failure and their MP level is very close to that 400 threshold, it's worth thinking, could this be altered by some of these factors? And if it is close, if it's 390, you might want to repeat it in 3 months' time just to see if it's gone over that threshold. Or you can refer to cardiology if you have a strong suspicion. Equally, if the NT-pro level is less than 50, it's very unlikely that the patient has heart failure. So on to the second of our papers. So this was published in the European Heart Journal, which is a big cardiology journal, one of the biggest in the world, along with Circulation. And as a GP, we were really pleased to get our paper in there. So we wanted to look at long-term trends in natriuretic peptide testing for patients with heart failure in primary care. And again, we use CPRD just to look at the trends over time. And what we found was that there was a real uplift in testing. So we looked between 2004 and 2018. And as you can see on the graph, there was a real increase at around 2010. So that does coincide with the 2010 NICE guideline being published. It also coincides with a lot more commissioning of MP testing. So as a GP in Birmingham, where I worked then, we got MP testing around 2011. And before that, we were only doing it in our heart failure studies. So there's a really big increase. And as you can see, NT-pro has become the dominant test now. BMP is still being done in labs, but NT-pro is much more stable. So it is the NICE recommended test. And interestingly, what we found was the median level of NT-pro BMP at diagnosis of heart failure hadn't really changed over that time period. So for patients with a heart failure diagnosis, the median level was around 1200. So the threshold for referral is only 400, but actually that the median level that we're getting is much higher than that, which suggests that we are diagnosing people at a relatively late stage. And also that hasn't budged over time, so remarkably consistent over the 14 years of the study. So these are the conclusions that we came to in the study. So there've been overall since 2004 a 17-fold increase in the amount of natriuretic peptide testing, which was good to see. There was more testing in older people and those that are socially deprived, which is appropriate because heart failure is more likely to occur in those with deprivation. But the heart failure detection rate had been pretty constant at around 10%. So for patients being tested, there was only around 1 in 10 then went on to have a subsequent diagnosis of heart failure. But I think this last point was the thing that really struck us. When we looked at the data, 3 out of 4 people with a new diagnosis of heart failure hadn't had an MP test at all in the 6 months prior to diagnosis. So in the conclusions, we recommended that further increases in MP testing are needed so that in primary care we can diagnose these people at an earlier, potentially more treatable stage. So what to do? I think there is a huge issue of heart failure awareness amongst the public, amongst patients, amongst clinicians as well. We need to think heart failure in order to diagnose it. And I'm on the clinical board of the Pumping Marvellous Foundation, which is a patient-led charity set up by a patient who has heart failure. And working with them, I came up with this acronym BEAT, which some of you may have come across. So breathless, exhausted, ankle swelling, time for a test. And it was based or sort of inspired by Fast for Stroke. That's obviously been very successful in terms of raising public awareness of stroke symptoms and time to call 999. What we want to do with BEAT is to get patients to be tested so they don't need to call 999. So they're actually tested in the community and stay out of hospital. So back to the final research paper, and this was published in Heart, which is a sort of BMJ, British-based cardiology journal. And we looked at the natriuretic peptide levels for the people who were diagnosed in our previous study with heart failure. And we looked, did the level at that point prior to diagnosis actually matter in terms of outcomes? And we looked at both hospitalizations, but also deaths in the whole cohort over the 14 years. And this is what we found. So the median time between MP test and heart failure diagnosis was over 100 days. So mostly way outside of those recommendations for 2 weeks or 6 weeks from the time of presenting to diagnosis. And over half of patients were hospitalised in the year following diagnosis. So these are patients that are diagnosed relatively late and are ending up in hospital at some point anyway. And heart failure related hospitalizations were twofold greater in those with a very high MP level. So this above 2000 group is the really high risk group. And what we found both in terms of hospitalizations, but also all-cause mortality was higher in that group at 1, 5 and 10 years. And these patients were dying of their heart failure. And this is just a Kaplan-Meier curve again, which shows the blue line is that very high risk 2000 and above group, which have a much worse prognosis than patients with the lower MP levels. So those were the three main papers. I could talk about primary care research and specifically heart failure diagnostic research all day. But those were the three key things which hopefully have contributed to our understanding of the heart failure diagnostic pathway. We have published quite a lot in the BJGP as well, looking at diagnostic accuracy for natriuretic peptide testing, and particularly looking at that 400 threshold. And our paper on REFER, which was a big diagnostic accuracy study, actually informed the 2018 guideline where we kept that level of 400. Now in Europe, the level is 125, so it's much lower, but they do far more echoes than we do. But we do know that about 1 in 5 patients will be missed at the 400 level. So that's why we just need to bear in mind patients who are at the threshold, just interpret that natriuretic peptide test in light of the other factors that could be affecting it. So as I said, heart failure has a huge gravity in terms of diagnosis, and support for patients is out there. You just need to know where to find it. So the Pumping Marvellous Foundation is a really good place to signpost patients towards. They have an online patient community which people can join, and they also have leaflets and things that we can give out to patients, so you can order them on there. And the British Heart Foundation do have some good videos on their website. So just in summary, I think heart failure diagnosis in primary care is something where we still have a lot of work to do, and that's hopefully going to keep me in a job for a while. But things we can do as GPs, think about heart failure, a patient's breathless, exhausted, ankle swelling, time for a test. natriuretic peptide testing is a key part of the diagnostic pathway, and the level of that test directly relates to the patient's outcome. Heart failure is a really frightening term for patients, and I think signposting to the support available is really important and something we can do to take away some of that fear. And I'd just like to finish by thanking all my colleagues at Three Villages. Hello. It's great to be able to have an NHS home as an academic GP, and I think that's important to keep it real for my research and to make it relevant for patients. So thank you.
Thank you so much. That was brilliant. It's really, really useful to hear that and to see the evidence as well that's underlying some of this. And clearly, critical, timely diagnosis of heart failure is the key and is really, really important. And yeah, no, that's great. Thank you ever so much. We do have some questions coming in on the Q&A, so I'm going to just run through some of those, Claire, if that's okay. The first one from Shamil about, is there any role for NP testing in the monitoring of heart failure?
Okay, yeah. Hi, Shamil. So at NICE on the 2018 Guideline Committee, we spent a whole day reviewing the evidence for NP monitoring. And actually, there was very little evidence that it improved outcomes in terms of reducing hospitalizations, improving mortality. So there is one recommendation in the whole guideline about NP testing monitoring, and that is to do with people who've just been in hospital, who are less than 75 and have an EGFR above 60. So in that very small select patient group, there was a study which did show some benefit in NP testing, but generally at the moment, and certainly for GPs, we would say NP testing is for diagnostic purposes only.
Great, thanks, Claire. That's really useful. Just another question here from Will. In today's NHS, we need to be establishing patients on heart failure treatment in primary care before they see a cardiologist, with the exception of Entresto, as the wait is otherwise too long and risk of hospitalisation too high. Can I get you to comment on that, Claire?
Yeah, it's a really interesting one. I think the NICE guideline is that patients presenting with symptoms need an NP test, then referral for a specialist to confirm that diagnosis. And I think because of the gravity the diagnosis has, I think that is important. Patients need to be seeing a cardiologist specialising in heart failure, ideally, to get that diagnosis. Part of the problem is there's two types of heart failure, as you know. So heart failure with reduced ejection fraction is where most of the evidence base is for treatments. We do know now that the SGLT2 inhibitors improve outcomes for HFpEF as well, so heart failure with preserved ejection fraction. They do that in terms of reducing symptoms and hospitalizations, but the trials didn't show an improvement in mortality. So the only drug relevant to both types of heart failure are diuretics or SGLT2 inhibitors. But I think, as with any condition, getting the diagnosis right is absolutely key. And certainly as a GP, I wouldn't feel able to give a patient a diagnosis of heart failure without that specialist assessment.
Brilliant, thanks. Yeah, thanks, Claire. No, I think that's really clear. Interesting question here about some of the labs and their rejecting BMPs on the basis of minimal requesting intervals, and a local lab setting that as at 6 months. Just wonder what your thoughts on that would be. Should it be 3 months in light of what we've just learned?
Yeah, so I had a meeting last week where one of the consultant pathologists from our local lab was on the call, and we discussed this because I think locally where I work it's actually 12 months, and she's agreed to drop it to 3 months after we discussed it, and I think 3 months is a reasonable amount of time. What you don't want is people having an NP test every couple of weeks, because NP, like everything else, can go up and down. So I think a 3-month repeat would be reasonable in somebody who had a borderline NP level below the threshold for referral, but you're still having looked at other conditions, still suspecting heart failure. So I agree that 12 months or even 6 months is a bit too long. I think they put that in to stop just ticking the box for MP at every opportunity. So yeah, certainly locally, we've talked to our labs and we've reduced it to 3 months now.
That's great, thank you. There's quite a few questions. I am mindful of time, so I'm going to just go for a few more, if that's okay.
Yeah, great.
An interesting question here on how good a marker NP is of overall cardiovascular disease risk, and whether or not there's a future model for it to be incorporated into cardiovascular disease models.
Yeah, so its use at the moment is predominantly for heart failure diagnosis, and that is something that we are looking at the moment, is how you can look at other factors to look at your overall risk of heart failure, and natriuretic peptide level is obviously part of that. I think certainly at the moment clinically, the use of it should be in people that are presenting with symptoms, and you as a GP suspect the patient of having heart failure. As we said, MP can be up for lots and lots of reasons, so it does need to be done in a very considered way. But in terms of a research question, we're certainly looking at natriuretic peptides in lots of different ways, including overall cardiovascular risk and also the age-related cutoff. So we're looking at the MP levels by age, because we know it goes up with age, and Europe have recently recommended that we take age into account when we're looking at natriuretic peptide results. But in the UK, we don't need to do that at the moment. So it's all still really straightforward: 400 refer, less than 400 think of other conditions.
Great. Okay, thanks for the clarity there. That's really useful. There's a few questions left, and what I was going to do, Claire, if it's okay, is I wonder if while I hand over to Alistair for the final few minutes, whether or not you might be able to type some into the Q&A if you can. If not, we'll make sure that we get answers back to attendees. And just before I hand over to Alistair, just to thank you again for that excellent talk. We're really helpful, really useful. I suspect there's scope possibly for you to come back and give some more information about that. So I'll just thank you again. I'll hand over to Alistair.
Thank you.
Thank you very much for handing over to me, David, and thank you, Claire, for an incredible presentation. Just to give everyone here a brief overview of actually what the Dare to Think trial is and what we're trying to actually achieve. So the Dare to Think trial is a large collaboration between the University of Birmingham Clinical Practice Research Data Link and the University Hospitals of Birmingham NHS Foundation Trust and other leading institutions across the UK. It's funded by the National Institute of Health and Social Care for research, and the trial was designed to answer a national call to improve the delivery of clinical trials in the UK. The trial looks to use routine NHS data to integrate clinical research into usual NHS care, reducing the burden on both NHS staff and patients and opening up research to a wider community, while also addressing the demand for a future-proof life science strategy to enable the UK to compete on a global market. The exemplar of this new delivery method, Dare to Think, is working nationally to recruit GP practices and patients to a trial targeting a key public health issue. Recruiting low-risk patients with AF and randomising them to receive early intervention with direct oral anticoagulants or to carry on with current NHS guideline care. The trial aims to prevent stroke, thromboembolism, cognitive decline and dementia, while also developing a future-proof trial pathway that can be used to answer key questions in a disease-agnostic way. Dare to Think is currently actively recruiting general practices and patients across England, and we have already seen a number of amazing achievements. The trial platform has been rolled out and to scale and can be used to remotely screen over 13 million patients for trial eligibility, with a complete remote delivery model, enabling patients to take part without leaving their homes, reducing the burden on both patients and NHS staff. Over 500 GP practices across the country are now signed up to be involved in this opportunity to potentially reduce vascular dementia, and we have had an amazing patient uptake into the trial with over 800 patients now recruited. The trial was designed with the aid of a world-leading patient and public involvement team, and has been involved in setting the global standard for research using healthcare data and leading the way nationally to provide an opportunity for the UK life science sector to improve clinical research for the future. As I said, we are still looking for primary care GP practices to be involved in the study, and this exciting opportunity to answer a key public health question. If you would like to find out how your practice can be involved, please scan the QR code on the screen, book a meeting with a member of our team, and we can talk you through what if it's possible for you to take part. And then that just leaves me just to hand back to David for any closing remarks.
Thanks very much, Alistair. Yeah, so as Alistair said, we're still currently accepting new practices for the trial. Please do scan the QR code. Sorry, it's just disappeared. It will come back, I think. And we'll just leave that up, actually. That would be great if you're interested, and we can get back in touch with you about that. I think it's been a really useful session. Thank you again to our speaker, Professor Clare Taylor, for that update. We really enjoyed it. I suspect that the bite-sized format that we've adopted to is good for people to fit in the middle of the day, between surgeries or whatever, and it would be great if we could perhaps have Claire back in the future to talk about another aspect of it. I think I personally find that very useful. And as ever, please do get in touch if you have ideas for topics that you'd like us to cover, or if the format could be changed in any way. So once again, thanks to our speaker. Thank you to you as well for attending today, and we hope to see you again at a future webinar and hopefully joining the trial. Thanks very much.